I'm so happy to have my friend and a great advocate for women's health with us today, Dr. Whittaker. Thank you so much for being here.
Oh, likewise. It's so wonderful to be here with you.
Yeah, you
Thanks
might know.
for
Yeah, you might know Dr. Whittaker as NaPro fertility surgeon online, and many of you probably follow her. So I had to invite her here on the audiobook podcast to talk about one of my favorite chapters, the farewell tour, because it kind of follows my progression through diagnosis and surgeries until I had my hysterectomy. And so I think a really great way to open up our conversation, Dr. Whitaker, is if you could explain to our listeners what is the difference between an OBGYN who graduates from school and just starts practicing, delivering babies and also doing surgeries, and a surgeon like you who's had some extra training and experience. We often hear of NaPro surgeons, but there's you don't have to be a NaPro surgeon to provide some really good surgical care. So we have restorative reproductive surgeries as well. Can you tell us what is the difference?
Yeah, so OBGYNs play a tremendous, wonderful role in keeping people alive. So, I mean, their bread and butter is delivering babies, especially even being able to take care of more high-risk situations, doing C-sections, managing pregnancy complications and delivery complications. And they also can treat more gynecologic disorders such as abnormal uterine bleeding, which can also lead to life and death problems. And so they have been trained, very highly trained in surgery and in medical interventions with that mindset of life and death mainly, which is super important, and we need to value that skill set. Now, with that comes limitations. And so their toolkit is not super wide as far as more quality of life or more abstract, like fertility, more intricate, complex conditions, or restorative mindset conditions, because that's more of an advanced view of viewing women's health conditions, right? We're not just dealing with the here and now, we're dealing with more preventative medicine, more restoring health, and restoring, for example, physiologic functions of the body, such as restoring tubal function. This is so far beyond the current model of just keeping people alive, which is absolutely critical, and we need to really honor and respect the expertise that comes and that's needed, especially as our society is growing sicker, right? So there's a growing need for OBGYNs to take care of women. And there's a national shortage already of that, which is concerning. Um, but we also have this growing fertility crisis, and we don't have OBGYNs that really are given the right training and knowledge to be able to deal with this, unfortunately. So I learned this because on my own personal journey, I was learning the Creighton model system and how to chart my cycle for my own personal reasons as I was gaining interest in women's health. And so my own journey, I got to see, well, I learned more about the women's menstrual cycle on my own time while a medical student, while an OBGYN resident in this training, and that it opened up my eyes that doctors don't really understand the menstrual cycle 101 or ovulation or what is normal. What's a normal menstrual cycle look like? Because they're taught how to keep people alive, for
Save
example.
lives. Yeah. That's crazy. I don't know why that kind of blows my mind a little bit, but it really helps me to understand. It puts it in perspective because it can be uncomfortable when you're trying to educate someone or just share with people that, if you're going to have surgery for endometriosis, for example, find a specialist. Don't go to just a typical OBGYN. Not that they're typical, but nobody's trying to replace them. Like there is definitely a need for that kind of thing. I think that really helps reframe it in my mind. So thank you for explaining that. It's just that there's something extra, something more for a completely almost like a new branch of medicine.
Exactly. I mean, we have a lot of subspecialties. For example, cancer care is something I like to compare to because they do tend to consider more of a whole person model, more, you have cancer navigators, you have addressing mental health. I really think fertility care should be copying that. And they
Yeah.
have 6, 12, 18-month outcomes, not just, oh, one cycle outcome, which doesn't make sense. 1 month will not treat a complex condition such as fertility.
Hmm.
So there are subspecialties within cancer everywhere. There's subspecialists for very sub cancer types of breast cancer. So, we need that. We even need subspecialists within endometriosis for fertility or this specific fertility or adhesions and
Yeah.
ovulation disorders. We should really have specialists specifically to ovulation disorders, for example.
Yeah, and I've also like it's helpful so that as a specialized surgeon, can devote all your time to that kind of work and correct me if I'm wrong, let the OBGYNs who are trained for that deliver babies. Would that be helpful for you if you could just focus on the surgeries?
I think I've heard a lot of arguments that make sense,
Okay.
right? Like, one person can't learn
Yeah.
all of women's health, the complexity of the human body, let alone the female body that we've only started to research since the 90s, really, and even that we've gotten the foundations of women's research completely wrong. So we have a lot of work to do,
Hmm.
and uh, correcting even from the ground up the menstrual cycle knowledge. Let's add the research to that and the complexity of endometriosis alone. That's just one women's health condition that we're talking about.
Yeah.
So it makes sense that, and it's again so forward thinking, like what we're talking about, and zooming out from our own life experience to be able to see this. And as a doctor, I'm someone I want to be able to have all the tools. I want to be able to do it all. Like there's some pride in that.
Hmm.
I get to deliver babies that I've um, helped a
Couples to
couple
conceive.
conceive, and
Mhm.
there's a beauty in that. But as a human being, we have limitations. We
Yeah.
have limited time and resources. And so really it makes sense if you have special gifts or knowledge that other people don't have to really focus in on those.
That's great. I think it shows your humility too. And for those of you, if you haven't read the book or listened to the last chapter that I read, chapter 15, The Farewell Tour, the reason I'm asking this is because this was my personal experience that I didn't know any better at first. And I went to an OBGYN who was great. Like I really liked her. She cared about me. Um, and she did my first surgery and she did as best as she could with the information that she was given and the knowledge that she had. And I really respect that. But because she didn't have this further education, which I want to ask you about next, um, my disease, it just wasn't properly taken care of. And because I wasn't on birth control that she prescribed, I knew that. Otherwise, the symptoms would have likely not been noticed. But because I wasn't on birth control, I noticed that my pain never got better and I actually had a new endometrioma develop. And I needed another surgery scheduled just 3 months after the first one. So, I'm a perfect example of, I think, how necessary it is to have someone who has that extra education. So, Dr. Whittaker, what is the extra education that you went through after you graduated as an OBGYN?
Yeah, I mean, on your case, yeah, so I'll go on to my education and then I would love to go back and
Yes,
see
please do.
your case and how understanding the model and the specialty and the expertise. In hindsight, things are clearer, right? And
Uh-huh.
so many people are where you started.
Yeah.
And so how can we use my knowledge and your experience to rehash that and see what we can do for others? And that's why we're here, right? That's
Yes.
why we're so
Yes.
passionate about what we do. So I spent an extra year with a pay cut. I could have made so much more money just going general practice right away. And I went to do fellowship. And so an apprenticeship of sorts to do more surgeries, just focus mainly on endometriosis, fertility, restorative approaches, so tubal surgery, ovarian wedge resections for PCOS, and just really diving in head first to that reproductive realm of just restoring health. I also had more time than because I wasn't doing a ton of deliveries and I wasn't dealing with the complicated high risk surgeries all the time. I had time to breathe and I had time to delve into naturopathic literature and just literature, just read everything, read the NaPro textbook, read naturopathic literature and just bridge all the connections. And I just saw these patterns. Like it's not allopathic medicine versus naturopathic medicine, for example. The truth of science comes out whether you read psych literature, naturopathic literature, or allopathic literature, you see patterns of where medicine needs to go. And so I was able to take notes, do complicated surgeries, and really have more of a year of reflection too, more than just go, 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 no sleep. The hours were better. Um, but really focusing on all the things I didn't know about endo, to be honest. I knew nothing basically about endo in my general training. And that's saying a lot because I did do my Creighton, I was a Creighton instructor. I did learn the Creighton method to teach to couples of cycle charting. And I did take extra NaPro courses in my medical school because I wanted to know as much as I could before even I stepped foot in general OBGYN residency. So I could somehow integrate it early on in my career, even very early. I wanted as many tools in my toolkit as possible. So I had already had some introduction into endometriosis from the NaPro way, and I was in NaPro surgeries as a medical student. So I knew excision, I knew laser, I knew what was possible. Then, but I still was just a student. I didn't quite put all the pieces together. No one really explained it. I just kind of experienced it peripherally and watched it in the OR. And again, it was so far beyond my understanding. I still didn't grasp it on a deeper level. So then in my residency, I then just operated with every local OBGYN and even one MIGS specialist and a NaPro surgeon. So I got to see the full scope
Real
of,
quick, can you just briefly explain what a MIGS surgeon is?
yeah, so minimally invasive gyne surgeons focus on pelvic pain and endometriosis and hysterectomy. So they don't really know how to restore health. So there's a huge gap between fertility doctors, specialists, which right now, unfortunately, is only IVF, it feels like. That's
Hmm.
their main toolkit. So are you an infertility patient? You're funneled to IVF. Are you a pain patient? You're funneled to MIGS.
Okay.
NaPro is in between, or restorative reproductive medicine is in between, where you bridge the best of both worlds into restoring health with an infertility lens,
Oh, okay.
integrating surgery. So it's its own field that has organically developed kind of behind the scenes,
Yeah.
a great niche thing that has met the needs of a market of people desiring it for personal reasons. They want natural methods or faith-based reasons. But there has been a push for this, right? And now it's getting more attention. But so I was more aware than most as far as in my general OB/GYN training when endometriosis was very poorly treated surgically. That's one thing I got to see. Oh, you're doing a hysterectomy for endometriosis, essentially. I didn't know that, but in the OR, I saw a big endometriosis nodule, and I'm like, "Hey, are you going to treat that?" And the gynecologist is like, "No, I'm just going to remove the uterus." I'm like, "But
Oh my
what?
gosh.
It's a big black nodule."
Yeah.
And so I saw some bad care, suboptimal, but meeting standards of ACOG care, right? That's meeting standards.
Right. Okay.
Removing the uterus, even though endometriosis is a disease outside of the uterus, you're going to remove the uterus, which reimburses more because the current model is broken, right?
Yeah, yeah.
Reinforcing this broken model. So, what I learned in fellowship is how complicated endometriosis really is as far as presentation. It can present in so many different ways with any individual woman is going to have her own symptoms and cycle charting patterns. And then at the time of surgery, it's going to look totally different in every woman too. It's going to have a total
Mm.
different location, different appearance. And so you really have to dive deep into it for at least a year. Really, it takes 3 to 5 years to become an expert, to be honest, as far
Whoa.
as top
And that's
tier.
in addition to like you've graduated as an OBGYN, then 3 to 5 years to become an expert at treating the
Feel
disease,
confident. I mean,
endometriosis.
you
Okay,
never
to
feel
feel
confident.
confident. Gotcha.
I mean, you can be really good after that year, but to like top-notch expertise takes at least 3 years. And it
Wow.
depends on your volume. It depends
Yeah.
on what complexity that you get. But you have to see patterns of these cases. You have to see complexity. You have to be in it. And then you also notice your brain notices all these patterns. For example, anything abnormal is likely endometriosis in a woman with either infertility or pelvic pain. Okay, so then
Huh.
you realize you have to know, be an expert of what is normal to know what is abnormal. And the same with the cycle. You have to be an expert of what is normal, which you're not taught in medical school, to know what's abnormal. So again, we're going back to the fundamentals we just don't know, right? Um, so then that's when I found out I had endometriosis in my fellowship year because I was doing endo all day, every day, and halfway through, 6 months in, I'm like, wait, I'm seeing a pattern.
Wow.
I have it too. I was 4.5 years into OBGYN. I was 7.5 years into, no, sorry, 8.5 years into my medical training myself, and how many 20 plus years of living with the disease. And finally, I'm like,
Oh my
maybe. And it's
gosh.
the whole thing everyone does. Maybe, maybe not. Maybe
Uh-huh.
I'm crazy. They're not going to find anything.
Uh-huh.
So just that's normal. So that's also why I made my 3-tier endometriosis symptom self-survey, because if someone had handed that to me 10, 20 years before and said, there's a pattern of symptoms, you might want to just think this might be endo. I wish I had had that. And so that's what I
Yeah.
made a resource, just to say, could it be on the radar? Should you be talking to people? Should you be looking into
Tell us
this?
about this resource real quick. Where can people find it?
armacademy.org.
rrmacademy.org.
Yeah, or anything's on my website, naomiwhitaker.com.
Yeah, and
And
so
then,
basically
okay,
she has these, it's you said it's called a three-tier what?
endometriosis symptom self-survey.
And it's really amazing, y'all. If you go visit there, if you have any questions about this and you're just answering a bunch of questions and it helps you to figure out if you have that going on. Okay, I didn't mean to
At
interrupt you,
least
but I want to
screen,
make
yeah,
sure
screen.
people
Mhm.
know where to go to find that.
Yeah. Yeah, it's a screening tool, so it's not a diagnosis tool, but it's great. Like I have all my patients fill that out, bring it to me so I have an idea from the get-go, kind of where they are symptom-wise, and then we'll delve into it. And it gives you a suspicion score, and the surgeon has to use that to talk to you about your case. But I love it for my
It gives you
practice.
some direction because, like you said, it's not like you can take a blood test and they can confirm endometriosis. It's
No,
not
and they keep
simple.
trying to sell that online,
And
and
yeah,
it's
there's all kinds of different things, and you just kind of like, well, what, maybe I do, maybe. So this just helps give you some clarity, some direction.
yeah.
Yeah. I mean, and you just kind of mentioned this, but I was the same. Like, I often wonder, you know, in retrospect, what if, right? Like, I started my period around 13 years old and it was painful right away. And then it just got worse over the years. And then it took me 12 years to be diagnosed, which is way too long. And I wonder what had happened, what would have happened had I gotten diagnosed if someone, a physician had done something other than offer me birth control at first OBGYN visit. Might have I been able to have children? How many fewer years of surgery? I'm sorry, pain would I have had? How many fewer surgeries would I have had? So if I were to come to you at 16 years old with pain, how would you have responded?
Yeah, I mean, I would have given you the survey, asked you about all your periods ever, if you're missing school, if you're vomiting, if just basic things don't help, right? You're maxing out on ibuprofen. I mean, some major red flags, especially, we would be talking about endometriosis and educating. So that's the main thing I can do. My job is not to say you have to have surgery, you need surgery. It's not life and death, but this is technically a surgical disease. And currently, ACOG and other medical societies all around the world, it's not just ACOG, it's all of them, scare doctors from recommending surgery for teenagers
Mm.
because they say, well, just put them on pills, it'll get them through. Then you don't have to worry about damaging their fertility. So it comes from a good place of doctors. They really don't want to damage the fertility of teenagers, and I really respect that. Um, and that's really important. You don't want to do more harm than good. You want to leave it better than you found it.
But the
Uh,
cost of doing nothing can be expensive.
exactly. That's the key that we forget too, though. But if you don't have the tools, then what else are you going to do? But
Right.
yes, no surgery is better than a bad surgery. Um,
Yes.
but we're
Say that
also
again.
no surgery is better than bad surgery,
Okay, thank you.
especially for a teenager. Oh my goodness. Because yes, it doesn't necessarily cause infertility either. So you could be doing more harm than good in a teenager, and that terrifies doctors. We really don't want to hurt teenagers, right?
Mhm.
So if we don't know how to do adhesion prevention, if we don't know how to restore fertility, it is the right answer to not give a teenager surgery from you. But the downside to that Dr. Patrick Young has found in his research of doing really high quality surgery is that you're missing an opportunity to intervene before the disease has done a lot of damage.
Mm,
So we don't really
yeah.
understand all the damage of years and years of chronic pain. We know for back pain, right? They're more likely to have, back spasms and it's going to
And
be hard.
pelvic floor issues.
We know for endopelvic floor. I mean, we
Yeah.
know this intuitively. The longer you live in pain, the body keeps a score. The harder it is to
Yeah.
go
Such a,
around.
yeah. Yeah.
So, so that opportunity of preventing 20 years, 30 years of pain, preventing all the bad outcomes that can happen when you suppress someone on birth control or Lupron, the menopause medicine, or early hysterectomy or early oophorectomy, putting them through menopause birth. And
Unnecessary, putting them through unnecessary issue like hysterectomy and
I mean, and that reduces life expectancy. So it does lead to poor quality of life and earlier death, so especially without HRT, which is also hard to get. So we can prevent pain. We could potentially prevent infertility. I remember one of my patients, I'll never forget. I treated her in her teen years. I believe it was advanced disease. I don't remember exactly the case, but I did find out she conceived on her honeymoon. We'll never know. Did we prevent
yeah.
infertility? I don't know, but I like to think that probably that she never would have to feel that
Well, you
pain.
gave her better chances for sure. It's so healing for me to hear what you just said because it's what I've written about and spoken about for so long. I just wonder, like, when I walked into my doctor's appointment, I just wanted her to ask me some questions about my cycle, about what my life experiences have been, but she didn't do any of that. Like, after I was just like, because I wasn't sure. I was like, well, they seem pretty painful, but like, we've just accepted that painful periods are normal across the board for all women. And that's just not the case, but I didn't know that. And she didn't do anything except what kind of birth control do you want? As if I'm
That's
supposed
all.
to know. Like what do you and I just declined and walked out of that doctor's appointment with everything
That's
in
all
town,
she had in her toolkit.
I know, and it's not her fault. It really, to the extent that that's what she was trained to do, but I just love hearing you say that you're doing what doctors, do, and you treat and you ask questions and you listen and then you have a treatment plan.
We do have limited time to listen in the current model. We have a limited knowledge of what to ask, of what's normal, and then we have limited options of how to treat. And so we won't be able to advance women's health without the research and the support of doctors in a better model. Because probably the reason she didn't ask you all those things because she didn't know what else to do. So
Yeah.
why even ask? It would be painful for her to hear all of that and
Yeah.
only be able to offer the same things.
That's
So,
fair. Yeah. Such
I
a
think
good
part of that,
perspective.
yeah, trying to again zoom out and try to understand everyone. Everyone, I do think most people are trying to do the best that they can with the
Yes.
resources of what they have. I think it's really important to even so kind of you to be so kind to the OBGYN that you know, there was harm related to that surgery that you didn't know and that she didn't intend, and you're so gracefully giving her the compassion in hindsight, even now that things are 2020.
Yeah.
We need to be doing a lot of that, both on the doctor side, on the patient side, to be able to overcome the barriers that we have right now.
With an appreciation for their limitations, for sure. I think that's fair. Something else I want to kind of shine some light on is something I wrote about in this chapter was an experience. It was really the worst pain I ever experienced. Not the only trip to the ER, but it was the worst trip to the ER. And I was throwing up in the car on the way. The pain was just so bad. And I got to, they put me in a wheelchair and they brought me in the back, and like I couldn't get still while the nurse was trying to get my blood. There was like blood scattered on the floor. It was just horrible pain. And then it wasn't until the second dose of morphine kicked in that I finally got to some relief. And they took me back after that for an ultrasound, and all they found were some fibroids. And they just sent me home with some pain meds. Now, I mean, I had enough experience at this point to kind of expect that, but I just, you know, you hear these stories. What are your thoughts on this? I'm sure like you've heard lots of things, but again, I just want to point out that this is what women with this invisible disease, one of the things that we have to go through, thinking that we're crazy or other people thinking that we're crazy because we're in so much pain, but it's just not a simple disease necessarily to find or to get help for. And so that's why it takes so long to get that help and that diagnosis.
Yeah, let me give you the perspective of an ER doctor.
Yes. Ooh,
They
please do.
are swamped. They're not given enough support. They're sometimes the whole unit is full of patients.
Hmm.
And one doctor, maybe with a couple PAs, running this whole unit of very sick people, and you don't know what else is going to come in the door. So their triage, they have to focus on who's the sickest. Who do they have to keep alive? Like
Keep
their
alive. Yeah.
job is to keep people off the street alive. I mean, lots of respect for someone who can do that. Someone walks in the door and their heart stops beating. That's what they're really there for. But
Hmm.
because of our broken healthcare model, people with public assistance uh, can only go to the ER for coughs. Like if they have a problem, they can't even go to urgent care because their insurance model only covers the ER. So the ER is also swamped with people that don't need to be there. And so
Mm-hmm.
they're doing urgent care, they're doing cardiac arrests, and they don't have enough support staff because the hospital is trying to save as much money as they can to be able to keep their doors open because reimbursement is low and maybe 30% of those people actually pay their bills as well. So we're dealing
Whoa.
with a very broken system,
Yeah.
okay? So there is a problem with money and where it's coming and where it's going and lack of that. And I don't have all the answers, but what I can tell you is perspective that these ER doctors are amazing people trying their best. So if a woman comes in horrible pain, they do take it seriously. Like they have to make sure you're alive and your vitals are okay. So your heart rate is probably high, but other than that, your blood pressure is probably okay. Your blood count's probably
You're not
decent.
dying.
You're not dying, right? Like these are the things they're thinking about. Like your blood count, yeah, you bled a lot, but they see blood all the time. What is your blood count? Well, do you need transfused or not? If you don't need transfused, if you don't need cardiac support, you're okay in their mind, right? It's all
Yeah.
relative. So they're not saying you're crazy. They probably don't even think so. They probably are like, well, it's gyn. It
There's
scares
nothing
me.
I can do about it. Yeah.
I
Except
can't
give some
save
pain
you here.
medicine.
I stabilize you, get your pain under control, and then you got to follow up and figure it out because they don't have the tools. There's no way, they don't really understand
Yeah.
endometriosis.
Yeah.
Uh, there's no way. How could they understand it? I mean, we're
Right.
talking about OBGYNs don't even understand it. How would an ER doc
All right.
understand
No,
it?
that's such a good point. It'd help if and then like the system is broken, so they're not going to refer you to a restorative reproductive medicine doctor, but that might be helpful. But the pain medicine definitely is helpful. I mean,
And that's beautiful.
it's just a tough situation, but thank God they're there to give us that, right?
Exactly. I mean, that guy, the fact that he gave morphine in that moment, that was so
Amen.
important. I'm so glad
Amen,
they did that.
sister.
They didn't say, well, you are crazy and send you out the door. They could have done that, right? I have a guy, his heart stopped. Like, what's your pain? Your vitals look fine, right? Like,
Right.
so it's so good that, I mean, I know that's not good care, right? For endo,
No, but
um,
it's helpful perspective again to
perspective.
remember that they're there to keep people alive. They don't have the expertise to go beyond that. And that's okay because there's other people that are here to do that. So I want to kind of transition. Thank you for that perspective, actually. I want to transition a little bit into crisis infertility, which is a term that you told me about, and it kind of like opened up everything for me. So can you explain? You have a lot of experience this. You've treated a lot of women struggling to get pregnant, many of whom have gone on to get pregnant, some you can't be 100%, right? So just tell us, what is crisis infertility and what are some of the dispositions you recognize in your clients who struggle with infertility?
Yeah, so at some point in a fertility journey when it's not going the way you anticipated, it could be, I think, 3 months into trying, sometimes 6 months, sometimes 12. Maybe it is the official diagnosis of infertility. There is a crisis feeling.
Yeah,
And it could, I'm not a psychologist, so I don't know, but I think it could be just a crisis of identity of sorts.
kind of like a panic feeling.
It's definitely panic.
Yeah.
But why is it so severe? I think it's a crisis of identity because you planned this. This was your plan. You were envisioning yourself as a biological parent, and now something's telling you it may not happen.
Hmm.
Whatever it is, this view of your life, of who you are created to be, is not happening. So it's a crisis moment of identity, kind of like a midlife crisis. We all identify that, but
Ooh,
now we're having a fertility crisis or a parent crisis, right? Or you thought of yourself as a mother, for example, your whole life. Perhaps you envisioned this, you played with baby dolls, right?
right.
No one, no one said you might be a statistic. You might be one that that it doesn't happen as easy as everyone else, it seems, in your mind. And so it's just something that just blindsides you too. And you don't know what's happening, right? Like you don't realize that you're starting to spiral because you're high functioning. Typically, you had your life together. Perhaps you waited, like everyone told you, you have your life together. Everything's gone your way because you're hardworking. And that's how life works. You get what you plan for. But this thing, this is unfortunately, right, a reality check in a way, a very harsh one, a very severe one, a very quick one, kind of like a death. It's very,
Mm,
except it's not as visible to the outside. And so
mm,
you add on to the very, very, the crisis, like a midlife crisis level, but worse, and you're younger and you didn't see this coming. You add that the invisibility of this suffering, and then it makes it worse. And then you isolate, and then it gets worse because the opposite of what you need to do is talk about it to your spouse, to your friends, to whoever, to a counselor, to a religious leader. And so part of that spiral that happens, you get deeper and deeper into it if you don't identify it. So I think it's just important that we recognize this is just part of the course. This is just
yeah.
normal, technically. I mean, it's not good, it's not healthy, but it's normal process of the infertility journey, and that we need to recognize this mental health obstacle so that we can identify it early, just kind of like endometriosis. Let's identify the mental health obstacles and signs and symptoms of a problem early so that we can say, look, I'm just this again. I'm not crazy. This is endometriosis. I'm not crazy. This is a symptom of infertility.
Yeah.
Let's identify that. How do men and women cope with it differently, for example? There's a whole different, totally different. And so if you keep spiraling and you spiral separately, the male and the female, they will turn against each other. It will get worse. And then in the middle of the spiral, um, so obsessing, ruminating, anxiety, panic, uh, probably lack of feeling happy. I mean, uh, for example, I mean, I don't have all of them off the top of my
Hmm.
head, but losing a sense of self, losing a sense of joy, stop not going on vacation anymore, trying to making your whole life revolve around this fertility journey as if you have total control. And so that's what it is. It's an attempt at total control over something you don't have control
But
over.
you can't have, you can't achieve.
So as you keep spiraling individually as a couple, you separate each other from each other, but also you may make decisions you will regret. And so it's really important to take a pause from this fight or flight that your brain, the amygdala, that's the fight or flight emotional part of your brain, has taken over.
And you might
So
not recognize. So I think it's helpful. You're explaining this because a lot of women don't recognize that this is a downward spiral. So recognizing this and kind of getting ahead of it doesn't mean you're not going to have any pain, but it's like you said, there's a healthy level of pain, and then there's when you dip too low. So being aware of this process that you can continue explaining is going to be really helpful.
exactly. And so you're in the fight or flight emotional brain. And so you're super triggered by everything, right? Like pregnancy announcements, which obviously are hurtful, but to
Hmm.
another level, there's a level that it can be taken to. But what you need to shift with support only, you need support to cope with that and get back to the frontal lobe before you make major medical decisions and financial decisions and spiritual and emotional and marital decisions,
Hmm.
because this is where your marriage will break. This is where your health could break. This is where your bank can break, because money doesn't matter if you just want a baby and you're in that
Such
spiral.
a good point. Yeah, you'll do anything. But you
Anything. I mean,
shouldn't do anything when you're in crisis mode. So recognizing you're having a crisis, even if it doesn't like, because people, we're always like, oh, people have it worse than me. Like this is just normal. But like, just to have a healthy perspective on things.
and there is a definitely part of the solution is gratitude for where you are, and
Yeah.
knowing that you are valuable as you are right now and like loving yourself for sure. That's huge. That's the identity crisis, right? Like I imagine myself as a mother, and that's where my self-worth and identity is. No, 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 no. It's not, right?
Hmm.
And all of us need this, by the way. So this
Yes.
is a crash,
Amen.
crash course in life. Unfortunately, it goes from third, some people take 30 years to experience it, and whoever's dealing with infertility, you have to do the 30 years of work in a year or 2 years or whatever.
Oh, yeah.
Yeah. Yeah, it's a crash course on your marriage, on your health, on your finances, on your boundaries
Huh.
in a very short amount of time. So
Wait,
you're
are
growing.
you saying, just so I understand, are you saying that like I mean, every woman who has children, maybe when around the time they reach menopause or their children grow up and move out of the house, they're going to have this, or usually have this kind of identity crisis, realizing that, okay, my children are gone, they're grown, I'm not going to have any more children. Is that what you're talking about? And then that's just happening sooner?
I guess I didn't even think of it that way,
Oh,
but
okay, because that's where
yeah,
my brain
no,
went. I was
that's
like,
true. That's the
yes,
same thing. No, you're
it's the
right.
same thing.
It correct. Yes, I didn't think of it, but yes, you're right, because they're losing their identity because they said I'm only a mother in some
Yeah,
ways.
yes, exactly. Yeah,
So yes, they're dealing with their what we always coined as a midlife crisis, identity crisis
earlier.
earlier. That's
Yeah.
very good. So get that out of the way, maybe before your kids even come. Prep
And
your
and
soul.
whether you're fertile or infertile, because it's coming.
Right, right. And but how beautiful. I just think of, wow, if your marriage is stronger after infertility and you set your boundaries with your friends, with your family, with your work, you prep the ground, your soil of your fertility, like nourished it with supplements. Like this is what restorative medicine is all about. So
Amen.
look at this beautiful opportunity. I know it doesn't feel that way, and it's not going to
Right,
feel good.
right.
It's horrible. I hate it. Like I hate
Yeah.
infertility so much. That's why I'm so passionate about it. It's one of the most painful things I've ever understood. Being a caregiver for people. Um, but all pain can be turned into purpose and, problems into opportunities. So there is so much good as a parent that you can take from it if you handle it in a healthy way. If
Hmm.
you unhealthy, we also see outcomes in children as being a problem. Everyone knows like that family that had a baby after infertility, no matter the outcome, like adoption or IVF or restorative medicine, we all know probably a baby that maybe was too spoiled, like, given a little too much because maybe that those parents didn't address those emotional issues in the healthiest ways. So investing in yourself now is being a parent, right? And
Yes.
I do think people, if they have that on their heart so much they want to be a parent, they will be. It just isn't always biologic because we can't
Right.
guarantee any certain outcome. But if that's on your heart so strongly and you are just so driven, so called to be that, you are nourishing your soul and prepping yourself to be that parent in whatever way you were called to be. You just don't see it now, but it
But
comes.
you will. Yeah, you
You
will.
will.
Man, thank you for sharing that. So I'm just curious, do you see a progression in your patients? Like, do you see them kind of shift? Can you talk about a shift that you see, whether it's, a shift downward and then another shift upward, or, talk about that, how through the course of your experience with them.
My goodness. Yeah, I've been so like humbled to be able to be with couples on this journey, so many, and watching them. And yeah, you see changes over the years if they do end up being a long-term patient. Um, and I would say just some people really become the most unbelievably different in the most beautiful way. People, I
Hmm.
mean, they all change. Everyone changes, right? From
Yeah.
a midlife crisis. Everyone changes.
Yeah.
You're going to change. Once you enter
Yes.
the crisis infertility mode, crisis identity mode, you walk out a different person. So you have to decide early on, as soon as possible, a roadmap as to where your boundaries are as soon as possible. That's probably one of the biggest things. As far as treatments, as far as marriage, like what are you going to put first? Faith, marriage, or the outcome? Just a baby at any cost. So
Ooh, good.
I see the priorities of people guiding the outcome as far as are they walking away better or are they walking away worse and shambles? Yes.
So if you put the outcome as the priority, it's more difficult, I imagine.
Depends on the
Right.
outcome, right? So the outcome, like what
Right.
I can't control is being there by my side by my spouse, no matter what. No matter who has a diagnosis of worse infertility, and it doesn't matter, it's us, no matter what. Or it's a baby no matter what, then your marriage isn't
That's what
important.
I meant by outcome. Yeah, like if you put, I guess to be more specific, the outcome is a baby no matter what, then you're going to have a more difficult time. But if your outcome is improved faith, improved health, like that's your goal,
I've seen
then
that flourish. And I mean, I've asked people, like, everyone's telling you just do IVF. Like, and your insurance plan is covering IVF, and you had 7 years of infertility. And I just recently had a consult, and she had conceived recently after 7 years of infertility. And I was like, you never did IVF. Like, tell me about that. Like, that's not normal. And you seem so like put together after all these years. I'm like, you got to tell me your story
yeah,
because
what's
I
the
know,
secret?
how did you do this? And she's like, I just really believed in my body, and like I felt like just God designed my body this way. I just really seemed like,
Just an acceptance for who she is and how God created her,
yeah,
it sounds like.
I think so. And she even had like her IVF coverage. It would have been cheaper for her to do IVF than restorative medicine, she said.
Whoa. Oh my gosh.
And it's called Carrot Plan, the IVF plan.
Okay.
Oh, Carrot, and it's with her work. I'm like, so it's like a dangled carrot in front of you. Yes.
Yeah.
And
Yeah.
she's like, yeah, so my employer was dangling it in front of me. All my friends are telling me to do it. My brain is telling me to do it. Like, and I did, and she didn't do it because we were talking about this. I was like, how didn't you?
Yeah,
And
and
so
it's IVF seems like the practical cho option, but it's not. It is still not the practical option. Well, financially, maybe you could
for her,
see that.
in a way,
And
but
for
then
her,
which
but
even financially it wouldn't make sense because she mainly with PCOS. So IVF makes no sense for
oh,
PCOS.
that's
Nicely, I said,
true.
we set up her for success to have a healthy pregnancy now. Yes, it took longer, but now she's less likely to have preeclampsia. She's less likely to have a C-section. She's less likely to
Mm.
have, you know,
So
poor outcome.
restorative medicine is the practical option for her, even though they're dangling this carrot in front of your face. No. So that's what crisis, understanding that infertility is a crisis can get us in a mindset where we can think rationally that even though this looks this way, this is not the most practical option. It is this way.
And of that case, she did not work with us for 7 years. She worked with us in less than a year and got pregnant. So, just if you get the right science-based care, it doesn't necessarily take very
Sure.
long. Yeah, just to
Yes.
clarify.
And we're going to wrap this up, but I just always want to kind of emphasize not everyone gets pregnant. I know you have a lot of wonderful stories, but not everybody's going to have that miracle pregnancy. And that is a reality that we have to consider that no one can promise us a baby. It is not a right. A child is not a right. A child is a gift. And to understand that, I think is going to really help our mindset and that what we can have is restored health, restored mind, restored relationships. We can have a healthy a healthy perspective on all of those things.
Right.
And when we go into the process like that, it doesn't mean we're not going to have pain. I mean, it's going to be difficult, but that you can be okay no matter what happens. That's what I
Exactly.
want everyone to
That's the
take
thing.
from the
We have
message
to spread that.
is that, yeah, this is it's a beautiful goal to be able to have a child, a beautiful desire, I should say, but it should never be our primary goal.
Right. Especially not biological. And yeah,
Yeah,
parenthood looks so different for different people. But yeah, unfortunately, the only milestone we think of, like you reminded me, is that positive pregnancy test. And that's what I use in this example as like, oh, this is a milestone, let's reflect. But really reflecting on other couples that weren't able to conceive that I've taken care of, they too are flourishing and so happy together and so strong and so beautiful too from the right mindset from the get-go. Not to say that they didn't hit low lows, they absolutely did, and
absolutely.
got
Yeah.
stronger from it. But the people that walk away better at the end don't necessarily, yeah, don't have biological parenthood is not a prerequisite for walking out better than where you entered at the beginning of this
And
journey.
like you said, part of the gift is that wrestling, is that falling on your face. That's what that was my experience is I
Falling is
learned
gross.
so
That's
much from that, that yes, those who have a pregnancy and have that baby, that's a beautiful gift. But, sometimes they don't end up dealing with what they need to deal with. They get the gift and that's a wonderful thing. But that both ways can be a gift. That's what I want to emphasize is that you're not losing out on everything when that doesn't happen. If it doesn't happen, because it could happen, you know.
absolutely
Yeah. Well,
great message.
Dr. Whittaker, thank you so much for having this important conversation with me. Is there anything else that you'd like to add, advice or thoughts, or is there a thing that you tell your patients or something like that? I don't know. Maybe there's not, but
Well, I'm so grateful that they're here listening to you and that they found your resources because that's really what helped me open my eyes. You said you had an epiphany moment, but I really reading your book and just following you and just understanding your experience and your what in hindsight, right? Your
yeah,
wisdom on the other side that other people they need earlier. Hopefully they can get it earlier. Kind of like hopefully you can help someone else get endo excision earlier, but also hopefully you can help navigate them to emotional stability earlier instead of just crazy waters on the ship. Let's have a little bit as we're coasting, hopefully, towards the end goal. The waters can be smoother. They don't have to be as crazy rough all the time. And if you feel like you're about to fall off the boat, then maybe we need a pause and reset.
breathe.
Um, yeah, so read all these things that I hope that you make. Also, other places like Springs in the Desert or Dr. Clay Brigance made a nice little pamphlet that's free at his website. And so there's so many resources out there. Just nourish your soul first, really, and your marriage. That is really where it starts. Because nothing else will matter if you lose who you are even, right?
Yeah, definitely. Thank you so much for that. You're such a gift to women and to restorative reproductive medicine, and we wish you all the best, Dr. Whitaker.
Thank you.